scientific meeting today, and a warm welcome to everyone who attends our meeting, especially Dmitry Sokolov from St. Petersburg, Public University. As you know, hemoadsorption therapy became part of the standard care during critically ill patients, septic patients, patients with severe rhabdomyolysis or hepatic failure. It's used in severe intoxications and so on. So I hope we will hear about new things, and I'm sure we will hear about new things. So Dmitry, please give your lecture, and I really appreciate that you're here with us today. Thank you.
Thank you. Thank you for this kind of introduction. It's a pleasure to be with you, to meet you, because it's very important to share the knowledge about this very promising techniques, I mean, the hemoadsorption. So my name is Dmitry Sokolov. I'm from St. Petersburg Public University. The university is one of the main universities in our country, and it's about 1,500 beds. We've got 6 ICUs, and every morning, every day, I'm dealing with critically ill patients. And within this time, my topics will be dedicated to critically ill patients who need adsorptive therapies. Mostly, I want to discuss with you their patients with septic shock and what do we know actually today and up to date about these techniques applying for these critically ill patients. Okay, so up to now, we know that there, and you know that sepsis, it's their worldwide burden. And we know from epidemiology that it's about the 10% of our patients, but the problem is the death toll is huge. It's about 40%. It's huge. And from the cost perspective, it's also very impressive because, for example, in United States, they spend, it's about their 5 up to 10 billions for patients with sepsis and septic shock. So that's not only the healthcare problem, but and social economic problem too. And okay, so to discuss their role, the key role of adsorption in treatment of critically ill patients with septic shock, and what do we know actually up to date about the role of adsorption in those patients? Let's try to follow with the pathophysiology of sepsis and septic shock to understand what possibilities we've got with these tools. First of all, we know that everything starts with their gram-negative bacteria. Why? Because you know and your ICUs and our ICUs, they are plenty with their gram-negative bacteria. And the first thing that the gram-negative bacteria in patients, they produce endotoxin lipopolysaccharide. And the thing is that lipopolysaccharide play a role in activating through toll-like receptor 4 leukocytes, and leukocytes start to produce high amounts of pro and anti-inflammatory mediators, aka cytokines. And these cytokines, they have their multiple features. First of all, they are engaged in immunothrombosis. So that's one of the part of their impairment of perfusion, tissue perfusion. And the other feature of cytokines, they activate their leukocytes and they activate endothelial cells on capillary wall, and they start to interact each other. And activated leukocytes start to produce collagenase, which is very strong enzyme which start to lyse their basement membrane of capillary wall. And at the end of the day, we've got these huge holes in the capillary walls, and we are observing clinically the capillary leak syndrome. It's redistribution between their fluids from vascular bed and interstitial bed. And this redistribution, fluid redistribution, is the main part of multi-organ dysfunction syndrome because their tissue edema impede their oxygen transport from hemoglobin, from the blood into the cells. And we are observing the mitochondrial dysfunction. We are observing in those patients high levels of lactate as their sign of their oxygen lack. And this nice picture is showing these huge holes that we could observe in capillary leak syndrome. These huge holes, they produced by leukocytes, and that means that capillary is no longer able to redistribute the fluids between vascular system and interstitium. This is the huge problem. First of all, I told you that our ICUs, there are plenty with their gram-negative bacteria. That's true. And this epidemiology from John Levy and Son was published in JAMA in 2017. And here you could see that their gram-negative bacteria prevails within the structure of bacteria in ICU across the Europe. And as you could see, it was done before the COVID pandemic. That's the problem because we have no data what we get after the pandemic. And here in my country, we have the results of our local study. And we observed that these numbers were grown. So right now, after pandemic, when we very widely used antibiotics before the patient gets to the clinic, before the patient admission, so this problem increased at the moment, up to date. So, of course, we have a problem. We have the affection of the patients. We have the spreading of the septic shock by bacteria or other pathogens. But we still have the problems with antibiotics. But we know that antibiotics play the key role in septic shock treatment. Yes, it's from Survival Sepsis Campaign, and we know that first of all, we should provide antibiotics. That's true. But up to date, we don't know other really new antibiotics which is able to kill any pathogens, I mean, any bacteria. This is quite problematic. And right now we are using the different combination of known antibiotics to try to enhance the features of these antibiotics to combat with the bacteria. And right now we have the device, which is very promising, which is called Seraph 100. It's the cartridge with the beads, which are covered by artificial heparan sulfate. And it's very interesting that this substance is able to withhold from the bloodstream different pathogens. But at the moment, this device was evaluated on animals. And right now, I checked it in clinicaltrials.gov. We have only 2 studies in progress that try to evaluate the efficacy of this device in clinical daily practice. Probably we will get in the end of the day very interesting device which enhance our ability to deal with the bacteria in critically ill patients in our ICUs. But we're still waiting for data from these studies to understand when to administer, how to apply, the timing, the time of treatment, everything we should know about this device, but it's quite promising, so we are waiting for the results. Okay, but as I said, the first is antibiotic. And we are prescribing antibiotics for critically ill patients with a sepsis, with septic shock. And we know that antibiotics have their impact on the bacteria, gram-negative bacteria. This is nice picture, shows how their E. coli reacts on moxapinam. And you could see here the burst of lipopolysaccharide into the bloodstream. And with this burst, via this burst, their leukocytes are activated via toll-like receptor 4. And this is their correlation between administration of antibiotics and their presence of lipopolysaccharide in blood of the patients with their sepsis. And it probably could play a specific role in septic shock development. In our minds, there is strict correlation between gram-negative bacteria and presence of the endotoxin in the blood in patients with sepsis and septic shock. But this nice, very good study showed one interesting result. It's Euphrates study, and later I will talk more about this very interesting study. But at this picture, you could see one interesting data, that the patient with their endotoxin in septic shock, their blood culture, gram-negative blood culture, were just 20%. And you can observe that even gram-positive culture, it's also were about their 20%. But those patients with the gram-positive culture, still lipopolysaccharide in the blood was detected. That is very important. And it's a reasonable question, what the source of this endotoxin in the blood of these septic patients if we have their gram-positive blood cultures. The answer is very, very simple. Because in patients with a septic shock with a multi-organ dysfunction syndrome, we have the problem with the GI. And in healthy people, their epithelium in GI tract play a role as the barrier, as the wall against our microbiota. And we know that in our microbiota, gram-negative bacteria are prevailing. And these cells, this epithelium, they are connected very tight. And within multi-organ dysfunction syndrome, the gates between those cells, they are impaired. And this pathway, leak pathway, which enables to translocate their huge molecules, I mean lipopolysaccharide and the toxin, the gates are impaired, I mean claudin, occludin. So in this condition, the lipopolysaccharide is able to translocate from GI lumen into the blood of their patient with sepsis and septic shock. So that means we are detecting their lipopolysaccharide even in patients with a fungi or viruses, even gram-positive bacteria in blood cultures. That is very important to understand that this is the way when we are able to detect the lipopolysaccharide in the blood of those patients. And we actually don't know what their share of this lipopolysaccharide and hemodynamic instability in this patient in sepsis and septic shock. septic shock mostly. This impairment of GI wall was proved on animals. And these nice pictures from histology from mice. So it was shown that in septic shock, this pathway was impaired, and they detected their endotoxin, the lipopolysaccharide, in the blood. So that's play one of the key role in aggravation of the status in these animals. Okay, so we understand that the endotoxin causes the septic shock and play a huge role in their septic shock development. But how we could eliminate their lipopolysaccharide from the blood in patients with septic shock? How we're able to do it with our hemofilters during CRT or another RT procedure? Absolutely not, because their molecule is extremely huge. It's about 1.5 million Daltons, so it's very huge. So the only one possibility to remove is to provide sorption. We know this meta-analysis and review provided by our colleagues from UK, and they showed that their absorptive techniques, they are able to eliminate their lipopolysaccharide and the toxin from the blood. And the thing is that it's associated with their survival benefits. It's very good. But you know that the work group of Survive and Sepsis Campaign 21, they consider it not so evident, that the evidence are not so strong from this meta-analysis, and they still require their better RCTs to define the recommendation about their hemoadsorption. But I want to point out one very good and with a good quality study provided by Dillinger in 2018, and I mentioned this was Euphrates study. It's double-blinded, randomized multi-center study, and the thing is that the primary endpoints were to evaluate the survival in the two groups: the patient who received LPS sorption and their control group with standard therapy. The thing is, they didn't receive any benefits at the primary endpoints from LPS adsorption. But the thing is that they took the patients with a moderate level of the endotoxin and high level of endotoxin. That's probably what the condition why they didn't get the result. But later, their post hoc analysis has been done, and what they found in patients with moderate level of lipopolysaccharide, there are clear benefits from LPS sorption. That's very important. So you know that they use their very interesting test, EA. It's quite fancy and probably arguable, but nevertheless, they found their good results if their endotoxin activity was in the range between 0.6 and 0.9. But you know, not every facility, not every clinic in my country is able to check this lab test to understand what their level of endotoxin the patient gets. And the thing is that while we are trying to elaborate our national guidelines for septic shock treatment, we look at the other very interesting study provided by our Japanese colleagues. And it was very interesting because they took the national registry And it was about 2,000 patients who received their LPS adsorption. And they divide them into groups according to the SOFA scoring system. And what did they find? That the patient with a SOFA score between 7 and 12, they get benefits from their LPS removal. And you could see just below there the share of these patients with this scoring system. What about half of the patients who were treated by LPS adsorbers? So it's very interesting. And when I formulated their recommendation in our national guidelines, I told that if you look at the patient and you observing their septic shock and the SOFA score is between 7 and 12, you might consider the LPS adsorption to get this patient improved from the clinical perspective. Okay, we know that from this post hoc analysis from their EUPHRATE study, where to find their survival benefits. And the work group of the EUPHRATE, they proceed with a specific range of their endotoxin activities. I said from 0.6 up to 0.9. And the recent data, they need 15 patients to stop the recruiting. And maybe next year, we will get the results. And maybe because the quality of this study is very good, maybe this result will be very good reason to define the recommendation in the next edition of Surviving Sepsis campaign. And probably this international guideline provide us their ability to very easy to use their LPS adsorbers for critically ill patients with sepsis and septic shock. But we should wait for the data, and I guess next year we will get them. So every time I was talking about their gram-negative bacteria, but you've seen from the epidemiology from EUPHRATES, there is the share of gram-positive bacteria. But do we have a problem with their gram-positive bacteria? Absolutely yes, because the lipotecoic acid is the same problematic stuff as the endotoxin, because it's the part of the outer wall of the gram-positive bacteria, and this substance has the same feature. It spurs the systemic inflammation through toll-like receptors and associated with the high levels of pro- and anti-inflammatory cytokines. But the thing is, we still are not able to detect and measure LTA. So this is the problem. And we still don't know adsorbers, LPS adsorbers or cytokine adsorbers, are they able to remove LTA from the blood from patients with sepsis and septic shock? We still don't know, but we have the way to proceed to understand their effect of adsorbents on LTA in patients with a gram-positive septic shock. I was talking about their LPS adsorption, and what do we know up to date? Probably their LPS adsorption in patients with moderate level of endotoxin is beneficial, and these patients they're getting their benefits from survival perspective. But I repeat, we need the result from Tigris to be absolutely sure about it. But what about cytokines? What do we know up to date about cytokines? So, because we know, and it was proved many years ago by John Callum, that patients, the critically ill patients with the high levels of pro and anti-inflammatory cytokines, these status is strongly associated with a huge mortality. And that's why right now we are living in the peak concentration hypothesis. So what does it mean? For example, the patient has pneumonia, and the septic shock was caused by pneumonia. And we are detecting their high levels of cytokines in this patient, and that's why we are observing their other distant organ damage. I mean, kidney impairment, liver impairment, brain impairment, other features, as we call it, multi-organ dysfunction syndrome. The idea of applying of blood purification to reduce this higher highest peaks of cytokines to provide their quite high concentration of cytokines in primal foci of inflammation, to provide this track for leukocytes to get into their inflammation site in the lung, and not to provide harm in other distant organ. That was the idea to apply their cytokine adsorbents for patients with sepsis and septic shock. How could we do it? And many times for 30 years, we thought that probably hemofiltration is able to provide very effective treatment for lowering the concentration of their huge peaks of cytokines in the blood of the septic patients. But this is not the case. And you could see here the endotoxin is not able to be removed by hemofiltration. And their guys, I mean, their John Callum showed that probably their TNF alpha could be removed by hemofiltration, but they were measuring a monomer. But we know in patients, the TNF alpha is trimer. That means the molecular weight of their TNF alpha, it's about 50 kilodaltons. That means we have no their regular filter, hemofilter, which is able to remove with convection, simple convection, the TNF alpha. That is problematic. That's why we need sorption to apply for patients with a high level of cytokines to get these levels less. Okay, we have a lot of studies that try to understand the effect of cytosorbents in patients with septic shock and understand how this situation is associated with their mortality and survival benefits. And last year, the guys from Germany, our colleagues, they published this review and meta-analysis. They review 34 studies, and they concluded that we still have no evidence of reduction in mortality in septic shock patients. But nevertheless, they said that we need well-designed RCTs to understand the way how to proceed with this treatment, because we have some points for beneficial effect with this device. So if we have no mortality improvement, maybe we have other features from these techniques which could be applied for patients with the sepsis and septic shock? Probably, but we should narrow the field where to find those patients. And this is a nice study provided by our German colleagues. It was retrospective. There is about 100 patients, and they were 200 patients, and they evaluated the effect of their cytosorbents in patients with septic shock. They tried to evaluate dynamic scoring system to understand when we could apply their cytokine adsorbents with the timing. And what did they find? Probably their earlier treatment with their cytosorbents is beneficial for patients with septic shock. And according to the scoring system, those patients were with their less than 6 scores according to this scoring system. But the problem is we still don't know what the share of their dosage of norepinephrine in this scoring system. Is this about their second vasopressor, or is this about their second bolus of fluids? Actually, we don't know. It's still unclear. But what do we know from this nice paper? That the patient who got their cytokine adsorption within 12 hours from the septic shock onset, they got their benefits from survival perspective. So that is one interesting direction to proceed. Probably we should apply this treatment to patients within 12 hours from the onset of septic shock. Another direction probably we should go with. This is also a nice paper from their Germany. It also was retrospective. It's about their 80 patients, and they try to figure out their survival benefits, but there is some fancy statistics, propensity scores, and we actually don't know what the benefit from survival perspective in patients who were randomized, retrospectively randomized for cytosorbents and CRT. It's arguable, I mean, from survival perspective, but what do we know from their cytosorbents group? The patients that were treated with cytosorbent devices and they had their lactate less than 6 millimole per liter, they get their benefits. The survival was higher. And that's very important because this is another way to proceed with when we are forming next well-designed RCTs and we were proposed with. Okay. Another interesting paper from Austria. This is about their 100 patients, and what did they found? The non-survivors, they had their high level of their lactate, and this data corresponds with the previous data. But what did they find very interesting thing? That's the patients who were treated by cytosorbents, they doubled down the dosage of norepi. So these patients were more hemodynamically stable. And this is very important. It was retrospective. But last year, the guys from Netherlands, Janssen and his group, they published very interesting prospective research. And in this study, they used the healthy volunteers who were injected with endotoxin and randomized for 2 groups with cytokine adsorbents and standard treatment. And what did they find? That their patients with their cytokine adsorption, they were hemodynamically more stable. And this is very important because we dealing with a patient with a septic shock, it's everything about their hemodynamic instability. So if we, at the end of the day, we will have a tool which is able to stabilize hemodynamics, it would be very good because we have to spare the time for antibiotics. We have to get the effect from antibiotics. It's very important. So probably with their cytokine adsorptive techniques, we could spare the time for antibiotic by providing the hemodynamic stability in patients with septic shock. Okay, so this is another very interesting prospective study, and it's very nice that this is Hungarian study. It was provided by your colleagues from Szeged University, and they get their 20 patients with septic shock that were randomized and treated with cytosorbents, and the results were compared with a standard treatment group. And what did they find? That the patients that were treated with cytokine adsorbents, they were statistically significant, more hemodynamically stable after 2 days of treatment. This is very important because this is quite small study, but the evidence is quite clear. We have to proceed with this feature of cytokine adsorbents. We need to stabilize their hemodynamics. But what some other points are very interesting from this study. It was clear that their procalcitonin was decreased by cytosorbents. And another very interesting substance was decreased. This is endothelin-1. Why it's probably is very important to eliminate these substances from their patient's blood? Because we have some scarce data that probably procalcitonin may play a role as the pro-inflammatory cytokine. And the high level of procalcitonin probably may maintain their high level of systemic inflammation. And this nice study was done in Germany in pigs, and they blocked procalcitonin with antibodies. And what did they find? That their pigs treated by antibodies were hemodynamically more stable than untreated, and they found that their renal function was better in pigs which were treated by antibodies. But what with their endothelin-1? It's also, we have some data that the endothelin-1 might spur their monocytes to produce high level of pro-inflammatory cytokines. And for TNF-alpha and IL-8, you could observe the labels are the same if their monocytes were spurred by endotoxin, the same levels. Probably this is another way to proceed with in evaluation of the effects of their adsorbents. I was talking about their lipopolysaccharide, I was talking about their cytokines. So, but we know that in critical patients with septic shock, we are observing the high levels of DAMPs. What's the DAMPs? It's substances that are produced by damaged cells, tissues. And their high levels of HMGB1 is strongly associated with their high rates of mortality in septic patients. But another feature is correlated with the high levels of HMGB1. It's their higher translocation impairment of GI wall. And I was talking about this problem because if we got the translocation of endotoxin from GI lumen in the blood of their septic shock patient, it could be very problematic. So this is interconnection. This is the vicious circle from septic shock and multi-organ dysfunction syndrome and dumps, pumps, and everything. So this is quite problematic, and we definitely need to interrupt this vicious circle. So, in the end of the day, we were discussing the different features of the lipopolysaccharide adsorption. So, probably we should provide this treatment to patients with a moderate level of endotoxin in the blood. Maybe in higher level of endotoxin in the blood, but we should increase the treatment to use more devices to eliminate the high level of endotoxin. But we need to evaluate the data from the next research. And we know that from LPS adsorption, probably the patient with septic shock, they have benefits from survival perspective. From cytokine adsorption, we still don't know actually the benefits, but we understand that they definitely get the hemodynamic stability. And it's a very important feature for the critically ill patient with a septic shock. And these two interesting and very important features, they are contained in afferent LPS, because this device is able to remove and LPS and cytokines simultaneously, and it's very important. And this very interesting study was done in my country. So it's about 60 patients who were randomized into two groups with LPS adsorption and standard treatment. There were patients with their gram-negative septic shock. And what did they find? The statistically significant survival was better in patients which were treated with LPS, afferent LPS. And it was very good, because if we have a closer look, these patients had their higher mean arterial pressure, they less required nor-epi, their respiratory function was more dysfunction, was better, the respiratory function in this patient. And their, according to SOFA score, the scoring was less statistically significant if we're comparing with their standard treatment group. Okay, so we've got their survival benefits in 72 hours in those patients with a gram-negative septic shock. But what interesting other outcomes they evaluated, they found? What about multi-organ dysfunction? So the patients who were treated with their adsorbents, they had their better respiratory function, and their cumulative MV weaning was more pronounced. I guess it's very good. So attenuation of the multi-organ dysfunction syndrome was quite clear. And this is the same clear for kidney dysfunction. In group who get their adsorption, their RT requirement was less than in patients in standard group. So I guess it's very important. And their procalcitonin, as I said previously, procalcitonin may play a role as the pro-inflammatory cytokine. And the reduction was achieved by using their adsorbents. So, but we have to understand one interesting thing. We, in their start of their quite long way, with very interesting and promising thing. We know their antibiotics is very crucial, and this is the key element of their treatment of the patient in sepsis in septic shock. And we know that delaying in antibiotics provision in every hour increases their mortality up to 8%. So it's quite huge. And we know that adsorbents, they reduce their MIC of antibiotics in patient's blood. And this is very important to mention. And right now, up to date, we have some data about their interacting their adsorbents and their MICs of different antibiotics in patients who were treated with the antibiotics and adsorptive devices. So mostly their anti-fungi drugs, they are decreased by these adsorbent devices. So this is very important to mention. And this paper was provided by Antoine Schneider from Switzerland, and I've met the Antoine last ESICM meeting, and I know his paper, and I asked him how to amend the dosage of their drugs, I mean antibiotics, in the patient who received who receiving their adsorption. And he told me we're increasing the dosage up to 30%. And this approach right now we are using in my university. We recommend to increase their antibiotics up to 30% when we're applying their adsorption in patients with their septic shock. So from the guidelines, you know that surviving sepsis campaign, it's very it's complicated. So for polymyxin B hemoperfusion, they suggest against, but they are telling that we need more clear evidence from well-designed RCTs. That's why we are expecting the Tigris to understand maybe we have their future to amend this recommendation. I mean about their LPS removal. But what about the other techniques? So surviving sepsis campaign right now do not provide any recommendation to use these devices for critically ill patients, but we have their ATKI group consensus, and they clearly stated that the extracorporeal blood purification techniques can be used in critically ill patients to remove pathogens, microbial toxins, inflammatory mediators, and toxic metabolites. So it's very important we have this recommendation from their ATKI group. We know that we have this situation because the sepsis is very heterogeneous. And in my talk, I try to outline the ways we should proceed with. So, from the LPS perspective, adsorption perspective. So, it's about Tigris results. I mean, in patients with moderate level of their endotoxin, and probably it will be good to worldwide application of LPS adsorption in patients with septic shock. But what with their cytokines? So probably it's about timing within 12 hours from the onset of septic shock. And up to date, we know probably this is the patient with a level of lactate less than 6 millimole per liter. So we have to provide new well-designed RCTs, and even I suggest to the work group who provide the LASSA trial to proceed with another multi-center randomized trial according to these directions. But their world-known experts, they understand that their infection and immune response, this is their primarily their pathological way leading to organ damage. And they outline their adsorptive techniques to interrupt this pathway and they focus in their researchers' endeavors to understand how to apply, how to prescribe the features of these devices. So we still have their two big issues. First of all, I mean, the first Big Bang theory that was formulated by Georges Lemaire in 1931. And we know the universe is expanding like their septic shock is expanding in septic shock patients. But the thing is, this hypothesis was published in Nature, as I said, in 1931. But Georges Lemaire said that we don't know actually what was the beginning. It was primal quantum, but we still don't know the cause of their universe, Big Bang. But from their universe of their septic shock Big Bang, we have some knowledge. And the source of their septic shock was discovered by Richard Pfeiffer in 1892 in Hamburg during the cholera pandemic. And there it was discovered, the endotoxin was discovered these days. So that's why we actually know the source of septic shock, and we have to deal with the source, I mean, and lipopolysaccharide. We have to deal with cytokines to get their benefits from patients with septic shock to increase their survival in these patients. So to conclude, I want to point out some very important things. So septic shock pathophysiology is very complex and it's problematic, still problematic. Pathogens, damp and PAMP molecules adsorption allowed to break the vicious circle in septic shock. And up to date, we know that LPS removal improves survival in moderate levels of endotoxin. And I said we need to wait results of other studies. Cytokine absorption improves hemodynamics, but we need to improve hemodynamic in patients with septic shock. We need to spare the time for antibiotics to get their results from them. Sequential extracorporeal therapy concept is very important, and its focus our endeavor to understand where and how and whom to apply adsorbents. But we need more well-designed RCTs. Definitely we need them. And at the market, the Efferon LPS probably is the only one adsorbent with their combined features to remove and LPS and cytokines. So that means this device is able to interrupt their pathophysiology of sepsis and septic shock, definitely. So I just a couple of words about our study that we are doing right now in my university. So we're trying to apply their Efferon LPS in patients undergoing cardiopulmonary bypass. We've measured previously their level of endotoxin in these patients, and it was moderate. It's about 0.4, 0.45 according to the EAA test. So that means when after the surgery, we are applying the norepi to those patients. And previously, we're discussing maybe this is their consequences of general anesthesia. We cannot clearly understand what their cause of this hemodynamic instability. But right now, probably these moderate levels of endotoxin play a huge role in their hemodynamic instability after the surgery and during the surgery. And maybe applying this device during their cardiopulmonary bypass, we could protect their organs and systems from harmful effect of lipopolysaccharide. So we are very enthusiastic, and I guess their results will be very promising. And that's all from me. And if you want to ask questions, I'm yours. So anything from you? Any questions?
Thank you, Dimitri. This was an awesome lecture. I think so. I don't know anyone has question. I have some comments or thoughts about your lecture. And thank you especially for your kind Hungarian words. Okay, so does anyone have a question? Yeah? Okay.
So, thank you, Dimitri, for your lecture. And my question is that the study you showed us about the high lactate level is with high lactate levels, there's no efficiency, there's no real benefit of starting an absorption therapy.
Yeah.
I just wanted to ask whether this level 6 lactate was the highest level measured, or was that the actual level at the start of the hemoadsorption therapy? Because I think maybe because high levels of lactate is a multifactorial thing. And I think besides starting antibiotics early in a septic shock, hemodynamic stability or starting stabilizing the circulations, it's very important. Maybe if we cannot achieve minimal stability, and this is causing our high lactate, this is one more factor that's leading to inefficacy. Or the other thing that that these are the patients where they are the too late to treat patients. What do you think?
Definitely, I agree with you because this was retrospective studies, so that was the problem, and they just find out that they're probably applying their adsorption techniques in patients with a lactate above 6 millimole per liter, not so associated with the good outcomes, but every study said that's probably earlier application of adsorbents associated with their more pronounced benefits. That's why I thought that probably this is the way to proceed. We should try to understand what the benefits from the timing perspective and from the lab perspective. So probably maybe it's not about 6, maybe it's about 4 or 3. Level of lactate. So I agree with you, but we need more data. But I guess we have the range. From if the septic shock, it's starting from their level of lactate 2 and more, probably the range is from 2 up to 6. And this is their area where we should try to find where our patients could get the benefits from their adsorptive techniques.
Thank you.
Yes, this was one of my thoughts also about the lactate and the SOFA score, because and about the mortality, because we know our patients and sepsis is a complex thing. So I think mortality is not the best outcome for clinical studies because patients are very similar but quite different.
Yes.
Taking one piece of the puzzle won't solve the problem. So, and the other thing that it seems that more severely ill is the patient. He benefits from hemoadsorption more and more, but there are patients who are too ill to treat. So I don't know.
I agree with you. So their mortality probably is not their primary outcome. So I guess maybe their hemodynamic stability should be evaluated first of all, because there, as I said, the septic shock patients, the heterogeneity is very huge. So first of all, we know that antibiotics they are first, and my guess with their adsorptive techniques, we have to spare and maintain hemodynamics to give the way for antibiotics to get with their better perfusion of organs and tissues to have their effect, to provide their effect. So my guess to do these adsorptive techniques to achieve good hemodynamics and wait for their antibiotics effect. That's why it's very important to adjust the dosage of antibiotics during this procedure. So it was the huge problem in my university. Actually, I didn't know previously. So I saw this paper from Antoine, but I had no idea how to do it in a correct way. So that's why I asked him, so how you do it in your daily practice. So right now we're trying to adjust antibiotics, provide antibiotics. First of all, we're applying their adsorption. Every time we're observing their hemodynamic stability, and we are waiting for their effects from the treatment.
Yes, it was quite interesting, and we were we were discussing about this topic also earlier, because if we think about CRRT, we adjust the dose of many medicaments, for example, antibiotics also. Why should it be different when using hemoadsorption? So, and I'm really happy to see this paper that you introduced about the dose adjustment of antibiotics during hemoadsorption therapy, because it was a big question among us also. And I've heard another very interesting aspect that I've never gone into deep or thought about it, that the role of antibiotics and endotoxin production or endotoxin burst into the bloodstream. Because
yes,
we know we use antibiotics to kill bacteria, but it destructs the bacterial cell wall, and the toxin release will be increased into the bloodstream. So may it be the future to use antibiotics and not consequent, but parallel hemoadsorption with LPS adsorbers?
I definitely agree with you, because this is, from my perspective, this is the only way. Because we have LPS, and as I showed, it's about the gram-negative bacteria in the blood. If we have gram-positive septic shock, the same problem. We've measured their endotoxin in patient, because we have this ability to measure EAA test in our university. So we've got their gram-positive blood culture, and at the same time we have their more than 0.6 endotoxin levels in these patients. What the source? And I told this is the guts. So that's why it's important. We are providing the antibiotics, and at the same time we have to provide something to eliminate their source of systemic inflammation. That's why I call this lecture the Big Bang Theory, because we should remove this source. And there is no straight correlation between this is only gram-negative shock or this is gram-positive shock. We are not able to provide their LPS adsorption. No, that's not true. And I've checked right now in clinical trials. There are not so much ongoing trials to understand the influence of adsorption on antibiotics. It's kind of frustrating, because it's very important. And from the CRT perspective, right now, at the moment, we know a lot. We have their very nice guidelines to amend the dosage of antibiotics during CRT. We're using the Stanford guide, and obviously you use the same, yeah. So, but we need the same guidelines for adsorption, the same. So I expected more than 10 or more studies that's recruiting the patient to understand their effect, their adsorption on MIC. But it's only two, only two.
Okay. Thank you, Dimitri. I fully agree with you. But unfortunately, our time is over. And I thank you for your time. And thank you for your really awesome lecture. And I hope everyone has learned a lot from your lecture, I'm sure. So thank you very much. And I hope we'll meet soon. I'd like to contact you in some days, okay?
Yeah, definitely.
Okay.
Thank you. It was a great privilege to be with you. And I tried to spell this actually, the Casoname. So maybe I was quite correct with their pronouncing, but nevertheless, thank you guys.
Thank
it was
you very
so
much.
Nice being with you.
Have a nice day. Thank you.
Have a nice day.
Bye.
Bye.